you able to see that okay?
Yes, I can. Thanks.
All right, excellent.
All right. So within our practice, a young lady, 43-year-old who was newer to our practice was sent to me for treatment for her hepatitis C. In general, good health. So her story was she started using injectable drugs at age 23, and it was around that time that she had shared needles with someone who she later found out had hepatitis C. She said probably first, let me see how long ago. Yeah. So that was like 19, 20 years ago. She got tested herself for hep C and they told her she had it. And then she was referred to somebody else and they tested again. They said she didn't have it. She said then she had this similar story happen to her about 10 years ago, was told she had it, got rechecked, and they said she didn't have it. When she had her child, who I think she said is 11 now, they had him tested and he didn't have it. So now she comes to our practice. They had done testing and they said, you have hepatitis C. And she was kind of like, well, here we go again. And in August, her HCV, there was 5,490. That was her amount. So they sent her to me and I do repeat testing. And this was at the beginning of April. And we can scroll down some, you can see her meds, just kind of some antidepressant kind of stuff and urinary drugs. Is her, when we, she is antibody positive, her quant was 180. And it said it couldn't calculate a genotype because of such low level. When her fibrosis score, she was F0, but she had this weird, her INR was high at 2.5. She had a pro time of 24/7 and an INR 2.5. She denies any history of alcohol. So then it makes her MELD score and her child Turco-Pu look really high because of this PTINR elevation. Her ALT 41, AST 30, bilirubin 0.2, her APRI was 0.193. So I had asked her, we've reached out to her to come in. I wanted to repeat that PTINR like a couple weeks ago, and she still hasn't come in for that because I didn't know if it was just erroneous or what. She has an appointment with me again next week. So her other thing in her history as a teenager, she had ITP, idiopathic thrombocytopenic purpura, one time. This was well before drug use or anything. And she said she may have had one other time where they told her her platelets were a bit low. Her platelets are fine now. They were 345,000. So I brought this to Echo to see, do we think she has a chronic hepatitis? Clearly she had it at some point. Is having a load of 180 now, knowing in August there was like 5,490 her quant. Does she need treated? I can't, it said it couldn't get a genotype because there wasn't enough quantity there. And what does everyone think about now? She has this high MELD and child Turco-Pu score. I'm not sure that's related to her hep C though.
Thank you so much.
Mm-hmm.
Excellent case presentation and definitely a great one for discussion. So does anyone have any clarifying questions about the case before we jump into the recommendations? Feel free to unmute or chat in.
Maybe I missed it because I came in late. This is Dr. Rexrod. Has she had imaging of her liver?
I don't think she did have imaging. Let me
Uh,
look. Because
just
when
curious
she
whether there could be
was,
something else going on there.
oh, sure, I've already let her primary know, like, she needs clearly more, and then her appointment to follow up with me is next week. She sees a different provider in the organization, and I'm like, this is gonna have to be worked up for sure. Um, yeah, I don't think, yeah.
Or I always think about family history of clotting disorders because we've got a couple big
Mm,
family cohorts in this area that some of their coags are wacky when they're actually leading perfectly normal lives.
yeah. Yeah, I would tend to favor that she has some clotting disorder that is separate, because she was fibrosis score F0 and it's been all this time. I do think she is going to need some imaging, but yeah, that's kind of where I was wondering too.
Hey, yeah, Kaylee and I were sitting here talking. I had to obviously start with the repeat INR assessment or pulling the fire alarm too hard.
Right.
And but yeah, it's wacky. In the MELD score and the child Pew stuff, we really only have to even calculate those because you're right, it's going to be so aberrantly screwed up by one measure. And it's unless you're really triaging a cirrhotic patient, that's the real role of those scores. So I agree with you, not really, paying attention to those. I'm talking about what I do know, and
Okay.
not the INR. So it's but her story is a kind of classic for somebody who runs a really low viral load, and periodically can, depending upon the limits of detection of the test, be told it's cleared. Often that's a misread. It's not really cleared. It's just lower than the limits of detection of the machine. So there'll be like a less than 200 or less than 20 or whatever.
Okay.
But it's quantifiable. The punchline is, she, given the time frame of her risks, she would qualify as a chronic Hep C.
Okay.
Your limitations for, and by the way, there's this weird, obviously we're happy with a lower viral load and her transaminases and everything, but it doesn't, all the viral hepatitis, whether it be B or C or whatever, do still have an ability to progress towards fibrosis formation and scar tissue, et cetera, even at low viral loads. So there's a tad bit of a disconnect, unlike HIV, where it's sort of like the most paramount number is the viral load. It's a little bit less prognostically important. You see viral loads that are sky high with no fibrosis, and those that are fairly low with significant fibrosis. So you can comfortably label her a chronic hepatitis C,
Okay.
albeit with pretty good immune control.
Mhm.
And you could treat her with a pan-genotypic agent, simply because you're right, the limits of the test will not allow you to
Okay.
differentiate the genotype any way that I know. I didn't look at her med list at all, Rachel.
Okay.
If there's any, so your pan-genotypic is clearly going to be Epclusa or Mavorite, but I didn't look at that going through. Kay, you got any other thoughts on her?
I don't see any drug interactions from looking at her list, but the only other caveat I'd say is, just because she's Medicaid, they may require a genotype before they will,
Yeah.
I mean, that's just one of their baseline labs that they require. But since in August she had a little bit, she was viral load was about 5,000, you could always repeat it again in like 3 to 6 months, and then just, if you snag it when it's elevated, then maybe you can process a genotype off that. But yeah, you probably won't be able to get treatment for her right now.
That's what I was, thank you for bringing that up, because I thought the same thing. I figured Medicaid would block me. So, but it helps me to know that you agree that yes, she needs treated. It's just trying to get it. Now it's going to be the authorization process, repeating the PTINR, repeating viral loads, and maybe trying to catch that genotype again. Okay. I appreciate that.
Clotting disorders, and again, I'm going to say the only thing I know about them, which is minimal. We always think of hereditary clotting disorders, but they're a good number. I've seen a handful of acquired elevated PTTs that's acquired hemophilia through autoimmune mechanisms. And, certainly just the milieu of Hep C is that of autoantibody formation. And she sounds like someone who's a tad pro to it. If she had ITP as a kid,
Right.
she got some
Good
autoimmune
point.
and whatnot. And
Mhm.
but you can certainly get antibodies directed against different parts of your coagulation cascade. And literally, I just exceeded my own knowledge base. I'm right there. That's the next word out of my mouth is hematology referral. I don't
Okay, thank you so much.
The only thing
Great
that I'll
case.
add in, this is Rachel. I agree with Kaylee. I don't see any major issues for either medication from a drug interaction standpoint. I can think of one instance where there was something very similar with a patient that had a low viral load and we couldn't get a genotype.
Okay.
And I'm pretty sure we had to have it a bit appealed and sent to Charleston, but we did get it approved without a genotype, but we had to fight it and demonstrate, like, here it is where the test says it's too low to produce a genotype here. But they, like I said, I'm pretty sure they denied it initially and we had to appeal it and send it to Charleston, and then they approved it based on that. So if you wanted to try to do that while you're waiting for her viral load to come up and maybe get it again later, it could be an option for you.
That's good. And maybe, if we get the official recommendations here and send that on, maybe that would help show support too. But I appreciate that.
I had one that was similar. Yeah. And we just
Okay.
sort of had to fight for a while.
Okay.
But we did eventually get her treated.
Okay. All right. There's hope. Okay. Good.
Thank you all so much. Any other comments about this case? And Dr. Fournier, other questions that you have about this case you would like addressed?
I don't think so.
All right, excellent. That sounds good to me. So it looks like Dr. Bailey is not on yet. I think she's held up in clinic. So I just sent her an email. So we'll stay posted on that. But Kaylee, if you don't mind, I guess we could get started with your didactic and then play it by ear and see if Dr. Bailey hops on so we can do her case at the last portion of the session. Is that okay with you, Kaylee?
Yeah, absolutely. Mitra, would you mind pulling my slides?
Absolutely.
And I'll have you scroll through them if you don't mind, or I guess I can if you share it.
No, I'm happy to. Just let me know next slide and I'll do that. Thank you.
All right, you guys. Today I want to talk about something that we've talked about it maybe kind of informally, but we have not done a didactic on this before, but it's managing hepatitis C treatment interruptions. And so kind of as we are utilizing our direct acting antivirals much more frequently now, and we're treating historically kind of more marginalized patients, it's almost a guarantee that we're going to see more treatment interruptions. And so that's, hopefully this will be somewhat useful. Go ahead and advance to the next slide. So objectives today are, defining what a Hep C treatment interruption is, considering various treatment lapse scenarios. And, I definitely want this to be more discussion than me just talking. So I definitely want some input of maybe experiences that you all have had. Describe some contributing factors leading to HCV treatment interruptions, and then review the available data that we do have, and also discuss some interventions to avoid or minimize interruptions. Next slide. So defining a treatment interruption, this is my definition. I can't find one anywhere, so this is mine. But I define it as consecutive missed doses during the course of HCV direct acting antiviral therapy. So I mean, pretty common sense, AKA a gap in treatment, inconsistent adherence, or you might see this as a treatment lapse. Next slide. So some various HCV treatment lapse scenarios. So you might hear, or I guess even on this call, my patient's medication was stolen, so they couldn't finish it. They started treatment a year ago, but then stopped due to side effects, and they still have active viremia. She might have received the first month of treatment, but then she relapsed in substance use and missed 3 weeks. What do I do? Or as some of our pharmacy colleagues have reached out to me multiple times, but we haven't been able to reach the patient yet to dispense the next fill. So let me just poll you guys. What other scenarios have you all kind of seen where someone has dropped out of care or had a gap in treatment? John says hospitalized.
The insurance company gave him 4 weeks and then couldn't get hold of him again.
Yep, for sure, absolutely. Incarcerations, I've had people that have like started and then they got thrown back in jail and couldn't get access to their medicines. Moving, yeah. Next slide. Let's go to the next slide and we'll kind of see. This is the list that I came up with. I'm sure it's not complete, but it was as complete as I could think of. But yeah, certainly hospitalizations or acute illness and they had to stop treatment because they were too sick to take it, or even exacerbated chronic illness and felt too ill to take their Hep C treatment. They were simply just lost to follow-up. We couldn't find them. Certainly substance involvement or relapse, whether it be that they had a relapse and just fell out of care, or maybe they decided to get into treatment or go through detox or rehab and we just don't know where they are. Incarcerations, having unstable or transient housing. Had a patient recently that separated from his wife for about 3 weeks and was like confident that she just took his medication, and I think he actually finished it, but he had gotten kicked out of the house, and so didn't think he had access to his medicine for a bit. Prior adherence issues, they just forget. Losing access to medications, certainly getting stolen, lost, maybe they moved and they couldn't find their medicine. Pharmacy unable to reach patient to dispense it. Clinic miscommunication, maybe we didn't explain to them the process of not having gaps in treatment or making sure that they got their next fill before they ran out. Maybe the patient was confused and misunderstood the instructions on how to take it. They stopped because they were having side effects, certainly insurance lapses or insurance issues of not getting the next fill dispensed, and then moving or relocating. Next slide. Look in the chat real quick. I thought, okay. So why does this matter? Certainly treatment interruptions, we worry that it may negatively impact sustained virologic response rates. What level of adherence is actually even needed to confidently achieve an SVR12? How many missed doses significantly impact this? Does the timing of treatment gap matter? Does it matter if it's within the first few days after they start and they have a gap? Does it matter if they're 4 weeks in and have a gap? Does it matter if they've already finished, all but the last week and then kind of fall off the wayside? When does it actually matter? What about genotype? Does treatment interruption matter more if they're genotype 3 versus 2? Does their cirrhosis status matter? What if they have several treatment interruptions? All these questions are great questions. But unfortunately, there's really limited data right now. Go ahead and go to next slide. So yeah, a few studies have actually evaluated this. I have a few studies that I just wanted to go through. This is what I could find. And just, 3 out of these 4 studies, they're not looking at adherence. These were more secondary analyses. What they were really looking at, or the primary outcomes were, they were assessing SVR rates in individuals with Hep C and pretty much, I should say, active injection drug use. The time frame, some of the studies was within the last 30 days. This one, I believe it was the last 6 months. So, but really, what I was looking at was more the secondary analysis. With the Simplify study, this was an open label single arm phase 4 trial that included really 7 countries and 19 sites. They enrolled 103, which doesn't seem like a lot, but this is just for the purposes of what I'm, their adherence, but 103 participants with chronic Hep C and recent IDU in the last 6 months. These patients were treated with 12 weeks of Epclusa, so sofosbuvir, I can't even talk, sofosbuvir velpatasvir. And 97% of those who completed treatment achieved SVR. So really high rates with our active injection use group. Then the secondary analysis really looked at, did adherence at all affect this, or one of the secondary outcomes? So they defined adherence as taking more than either greater to or equal than or equal to 90% of the doses. They found that a third of the participants were non-adherent, so took less than 90% of their doses. And despite that, really there was similar SVR12 between the non-adherent and adherent participants. So it was still about 94%, which is, pretty good. In most of the cases, commonly the episodes of treatment interruption really only lasted 1 to 2 days. That was 61% of the interruptions were that short of a period. 11 patients had one episode of missing greater than or equal to 7 consecutive days. And despite that, 9 of those, so they had data on 9, they still finished treatment and they didn't have any virologic failure. So that was the Simplify study. Next slide. Anchor study was what it was looking at was they looked at a single site in Washington, D.C., and it was looking at participants who had opioid use disorder, injection drug use, and chronic hep C, and their injection drug use timeframe was within the last 3 months. Again, they treated all these patients with 12 weeks of Epclusa. The way that they measured adherence, they had electronic blister packs. They dispensed 1 fill. So the first 4 weeks at the entry visit, and then the second fill or additional 4 weeks at week 4, and then the third fill, at the next 4 weeks. They also had a really high SVR rate. They did note that SVR12 was higher in patients who had were also receiving concurrent opioid substitution therapy than those who opted not to take that. They did note that so 93% were in the initial intent to treat analysis. 59 patients completed 12 weeks of treatment, but not all of them completed it on time. Despite that, so 52 of 58 patients, or 90%, achieved SVR at the 24-week follow-up. The other patient, the 59th patient, I don't believe that they had the ending lab data on that patient to include them. They also noted that treatment interruption was not associated with significant differences in SVR12 rates, but it was significantly reduced if the patient did not complete more than 4 weeks of treatment. So if they completed or picked up at least 2 bottles, then they had similar SVR12 rates as though they had completed the full course. Next slide. And then I have to mention the HERO study because our own Dr. Judy Feinberg, this was her study, or she was one of the co-authors on this study. But again, also looking at primary outcome SVR12 rates in individuals with active injection drug use. In this study, it was within the 90 days preceding enrollment. 623 patients were included in the modified intent to treat analysis. Overall adherence with the study was less than 90%. So they still had very high SVR12 rates. So participants who missed more than or equal to 14 consecutive doses, so 2 weeks of therapy, they did have a significantly lower SVR12 compared to those who missed less than 7 doses. So those who missed more than 2 weeks, about 85% still achieved SVR12, which is actually still pretty good, I think, compared to those who missed less than 7 doses. Those who missed less than 7, almost 97% of the time achieved SVR12. Those who missed between 7 and 13 consecutive doses achieved an SVR rate of 92.9%. again, this was secondary analysis, was looking at adherence, but they did note that increases in adherence and treatment completion were associated with an increased likelihood of SVR, which we can assume. Next slide. This is the only study I could find as of yet. So actually, I just want to, you don't have to go back, Mitra, but yeah, Dr. Feinberg's study was just published on November of 2022. So that's the newest one that I could find. This last study that was in the Journal of Viral Hepatitis in 2021, this was the only one I could find that was actually looking directly at adherence. And they did note that there were high rates of sustained virologic response despite premature discontinuation of DAA in HCV infected patients. And so, you know, they looked at people that didn't complete the full course. Again, this was also sofosbuvir, velpatasvir, Epclusa. They honestly noted that 99% or 109 of 110 of the participants who received more than or equal to 4 weeks of treatment achieved SVR. And then with the cirrhotics that were in the group, 95% who took more than 8 weeks achieved SVR. So 209 of 221 of the participants. The Simplify trial and then this study, you know, actually a fair amount of genotype 3 was represented. So in this one, it was, I think, about 68% of those that they reviewed had genotype 3. So that was something else. You know, you kind of assume that if any of the genotypes had lower likelihood of SVR with treatment interruptions, it would probably be our genotype 3. But you know, honestly, this was still very high rates of virologic response. Next slide. So what do our treatment guidelines say? The AASLD and IDSA HCV treatment guidance, this is like as fresh as we can get. You know, I can't remember, they updated it this year, but I don't remember how recently. Their recommendations, they do have a little table of recommendations for how to manage DAA treatment interruptions. But I do want to point out, this is only for treatment naive patients, those that don't have cirrhosis or have compensated cirrhosis. Even though the studies that I mentioned were all looking at Epclusa therapy, they also included the other pangenotypic Mavorite. So this is for patients that are receiving a pangenotypic agent. They did make sure to note that this is really based on the panel opinion because of the lack of data. But their recommendations are, if there is a treatment interruption during the first 28 days of therapy, so the first month, and the patient has missed less than or equal to 7 days, go ahead and restart the therapy. There's no need to wait and get a viral load first. Go ahead and restart it, and then go ahead and complete therapy for the originally planned duration, whether it be the 8 weeks or 12 weeks. If in the first 28 days, they've missed more than or equal to eight doses, again, go ahead and restart, but you still want to check an HCV RNA as soon as possible. So you shouldn't wait to check the PCR first. Go ahead and restart, but you do want to make sure you get that additional PCR test as possible, preferably the same time you restart their therapy. If their RNA is negative at that recheck, you go ahead and complete the originally planned course. If they have genotype 3 or cirrhosis, they recommend considering an additional 4 weeks of therapy. If that PCR is positive, or you just can't obtain it for whatever reason, then they also recommend extending the course for an additional 4 weeks. For individuals who have treatment interruptions after they've already received the first 28 days of therapy, again, if it's less than 7 doses or equal to 7 doses, go ahead and restart their therapy and complete it as planned. If they miss 18 to 20 consecutive days after that first 4 weeks of treatment, restart therapy. Again, draw your viral load. If the RNA is undetectable, still complete the course. and also extend treatment again for 4 weeks if they have genotype 3 or cirrhosis. If their HCV RNA is positive, then they recommend that you actually stop therapy and then retreat according to recommendations in the retreatment section. If they miss more than 21 consecutive days, then they assess or they recommend that you actually stop DAA treatment, go ahead and assess for SVR12. If it's not been achieved, consider retreating according to the recommendations. And again, I mean, I think one of those is if you do stop, you have ongoing viremia at that point, you know, you may want to, at that point, obtain your resistance testing as well, which is part of the recommendations in the retreatment, but I just wanted to point that out. All right, next slide. So what kind of strategies can we do to minimize treatment interruptions? I mean, obviously there are so many factors that can come into play. You know, it's probably near impossible that in the time that we have to follow our patients or to see our patients in that visit, that 15-20 minute visit, that we're going to be able to do a very thorough assessment. But, you know, we should be openly discussing the patient's motivation or readiness for treatment. I think we do get pretty comfortable now since we have so many treatment, you know, most of those treatment restrictions have been removed, that we kind of get pretty gung-ho. We want to treat as many patients as possible, but you know, on the side note of that, we really want to treat as many patients successfully as possible. And so we really need to be identifying any kind of co-occurring issues or social determinants that might potentially affect their adherence, and really come up with a personalized game plan on how to avoid those. So usually kind of my spiel is, you know, if I've identified, you know, some potential barriers that I'm a little bit concerned about the patient not being adherent, I bring that up and I ask them, you know, what are their solutions? What do they think that we can do to help kind of work around those? Incorporate telemedicine when appropriate, develop a system for follow-up, and then, you know, certainly all patients that have incomplete adherence should really be asked about contributing factors and counseling provided. Another thing I do is I make sure that the patient, before they start treatment, you know, I have a phone number for them, but I also make sure that they can provide me with like a backup person or a backup contact, and that they know that they need to identify somebody that they trust, that in the event that they get incarcerated, that they get hospitalized for whatever reason, and they can't themselves let me know what's going on, that this individual can, number one, have access to the medication to get it to them, but also that that individual knows to reach out to me and has my contact information, to kind of help facilitate them getting their treatment and not having a prolonged gap in therapy. Next slide. So summary, you know, missing doses of DAAs is relatively common. Longer durations of mistreatment or not completing treatment most significantly impacts SVR. We certainly have limited available data on how to manage these patients, especially those who have discontinued DAAs for several days to several weeks. There's lack of data on how to manage prior DAA treatments, those who have received other DAA regimens than our pan-genotypics, how to manage those that have treatment interruptions and have post-transplant or decompensated cirrhosis. So the recommendations from the HCV guidance is to consult with an expert, and I don't know who that is. So your guess is as good as mine, but you know, if we have that come up, we will certainly, you know, do our best to try to individualize a plan. And that's it, guys.
Thank you so much, Kaylee. Another wonderful presentation from you. And we just always appreciate your time and expertise that you share with this group. So thank you.
Thank you guys so much. And Dr. Bailey's on. So are we going to get to do a case?
Heck yeah, we get to do case. Hey, Dr. Bailey.
Hey, how are you guys?
Good. How's it going? Sorry, we went into the didactic and then we wanted you to have some time. I know you didn't want to, you had your clinic running long. I didn't want you to rush. So it's great to see you.
I appreciate that. It's good to see you guys.
Were there any questions about Kaylee's didactic? Dr. Rexford, I saw you unmuted, so if you had a question, I didn't want to skip over that really quick.
Oh, I was just going to say that Kaylee may not know who the expert is, but we do. We're going to call her.
That's exactly what I was thinking.
I love you.
That's
I love that. Thank you, Dr. Rexford. Any other comments, questions? All right. Okay, Dr. Bailey, I'll screen share and I'll pull up your case for you. Let's see here. Are you able to see this okay?
All right. So this is a patient that established care with me just a couple of months ago. He, I sent the med student in to see him. I knew nothing about him. But as it turned out, he is the father of one of the families that I take care of. I see his daughter, his son-in-law, and his 4 grandchildren. I think as family doctors, we have like milestones that we complete, and they're my first family of 4 kids that I've seen every child from birth to now. So I know this whole family pretty well. But I didn't know about the grandpa. So the patient that we're talking about today is grandpa. So he had been living in the Roanoke, Virginia area for years, and he was kind of marginally housed. He lived in a van for a really long time. He was diagnosed with HIV back in 1997. At the time, he was with a woman who was diagnosed with HIV, and so he went and got tested and was positive. He also reports that he was diagnosed with leukemia at the same time. He kind of said that his partner at the time had other risk factors, but he says that he's never really done any IV drugs. He doesn't have any recent drug use except for marijuana, which he uses for abdominal pain and appetite stimulation. I think he's got his medical marijuana card. And a few years ago, his daughter and his son kind of figured out where he was and got really worried about him, and they bought him a trailer and put it in the daughter's backyard. And so he's been living there for a while. I get the impression from him and from his daughter that he's always had a lot of mental health problems that have been not well addressed, that have kind of kept him from being around and have put a lot of barriers up between him and his family. But yeah, I think he was a good dad when he could be, and he's certainly a very sweet guy, but he's got some limitations as far as what he can do. He told me that he was diagnosed with lymphoma in the 90s as well, and he refused treatment for that because he was fearful of the chemo side effects. He is following with a hematologist now. I'm really struggling to get records for this guy. I know his neurologist is doing some testing on him too, because he has a lot of neuropathic pain, which I know sometimes can go along with HIV. But I'm having trouble coordinating care with them. So I'm hoping that I can make a phone call and hopefully improve that a little bit. He's pretty cachectic. His BMI was 16.8, and he has lost a little bit of weight since the first time I saw him to the second time. He had really requested to see GI because he was having a lot of abdominal pain whenever he first came into me. It's actually why he came. But he was incredibly constipated. He was having like 1 bowel movement a month. And so I got him on a good Miralax regimen. And he's having daily bowel movements now. So he's not really complaining with abdominal pain anymore. So that's good. So we got some blood work on him. He's Medicare, and he's got he's got some disability income, and so he does have to make his co-payments and everything. So he was pretty hesitant to get a lot of blood work initially. He asked if I could just get his records from the other providers that he had seen, and so we're still trying to do that. But I did get some basic stuff. His white count, you can see his lymphs were really low. In fact, we tried to get a CD4 count and they couldn't calculate the CD4 count because his lymphs were so low. He was anemic. His platelets were okay. EDS only showed THC. His HIV antibody was positive, and I scroll down a little bit more. Do I have anything else on there? I want to say that I had since I submitted, maybe got back a genotype. Let's see. Yeah, I did get back his genotype, but it's not there. So he's B, HIV-1 subtype B. And I've got his sensitivities here. Looks like he's pan sensitive to every antiviral that they tested, the gene for. So, and then his viral load was 85,000. So, current medications are listed. He's not really taken very much. He's not been sexually active for a long time. If you'd scroll down a little bit more. Okay, yeah, so we did have the viral load whenever I submitted, but the genotype was still pending. So it's HIV-1 subtype B. So I guess my question for you guys, this guy is very resistant to doing any type of antiviral. I guess he's had bad experiences in the past, and he has friends who've had bad experiences. And so he's kind of convinced that antivirals will kill him. I think he would be willing to do prophylaxis. So I think that's the main question that I have for you all today is, what would you do for this fellow for prophylaxis? And would any of that be affected by potential cancer diagnosis?
Thank you so much, Dr. Bailey. What a great case. And we haven't had an HIV case in so long, so we appreciate you bringing this to the group. Any questions about the case for Dr. Bailey? Carolyn, I see you.
I do. Hi, Dr. Bailey. It's Carolyn from the AIDS Education Training Center. Just listening to some of the history and background of this gentleman. Are you connected with the Ryan White Part B case manager in your area for like the drug assistance program? And they can provide anything from housing to food vouchers, transportation, et cetera, et cetera.
No, but that would be great.
Okay, so in order for me to give you, and I'll drop the name and number in the chat.
Thank
But
you.
what county are you in? And I'm sorry, I forgot.
Wyoming.
I'm sorry, what'd you say?
Wyoming. Sorry, I'm having my chicken sandwich between words.
That's okay. All right. So you're in Wyoming County.
Mhm.
So your case managers are Sharon Smith and Robin Abrams.
Okay.
So I'll tell you what I'll do if you don't mind. I'm going to drop their information in the chat, but I'm going to send them an email and I'll CC you on it.
Awesome.
as like an introduction, because they can do all kinds of things for HIV patients in your in their region, which includes your area.
Okay, that's great. I did think of another question actually. He said that when he got his lab bill, he said the only lab that the insurance didn't cover was the HIV test. He said, and what I'm hearing is that Medicare doesn't cover HIV tests. And well, yeah, that's an issue that we've had, is that Medicare doesn't want to test people for HIV. But this guy, we're not testing him for HIV. We know he has HIV. Are there any known issues with getting Medicare to pay for HIV tests for people who have HIV?
I mean, not that I've heard of. I mean, I know that, well, for people to get tested the first time, like diagnosed or if they're positive, if it's under Medicare, I know there are some parameters and some as well as Medicaid, but just to get the usual every 3 months labs drawn. Is that what you're referring to?
So I'm not sure. Yeah, I asked him to bring the lab bill in.
Okay.
He hasn't done that yet, but the only thing I could think of is he had whenever he first came in, I had one of the nurses put in his labs, and they got an HIV antibody, which we didn't need. We needed a viral load.
Okay.
And so I wonder if the antibody test is what he ended up with a bill for.
It may have, and I'll tell you what, make sure, if you can, that either he keeps that bill or you guys keep it for him or what have you, because the case managers can help with that.
Okay, great.
Okay, they actually are so good at their job, and they can take a lot of pressure off of you guys as the providers and care staff.
Yeah.
So I'm going to drop their names and numbers in there for you, and then I'll send an email, like an e-introduction,
Great.
and include you on it, Dr. Bailey.
Okay, that's wonderful.
All right.
Thank you so much, Carolyn. That's really helpful. And John and Kaylee, I saw you guys had unmuted briefly there.
Oh, yeah. Kaylee had a question.
Well, no, Carolyn kind of answered it already, but yeah, Dr. Bailey, I think it's more, Medicare has some funky coding, codes for HIV screen. So I can almost guarantee it's the HIV antibody and it's just a coding. I can send you the common codes that I use, because most of the time when I'm trying to get HIV screening covered with Medicare, I can't remember off the top of my head, but it's kind of it's like some really random code, like screening for exposure to communicable disease or something. It's just something that seems like it would be way more generic than an HIV test, but the case manager should be able to help work through that. But I agree with you. I can almost guarantee it's probably that antibody test is what he got billed for.
Okay, yeah, those codes would be helpful for us in general, because we would like to be able to screen our Medicare patients. We have a big Medicare population that's younger because they're disabled from working. So
yeah, I will tell you the main reason why I know is because with our system here in Epic, when it'll give me a flag that says it can't bill it under my code, and then there's a little drop down box that I can choose an appropriate code. So that's the only way I know how to do it, is because it prompts me. But I can definitely send you a list of those. Yes.
okay, yeah, that would be wonderful. I really wish our HR did that. That would be great.
All right, Joanna, you ready?
I'm ready.
So the prophylaxis.
Mhm.
He needs PCP prophylaxis.
Mhm.
And I would not comfortably give this guy Bactrim unless you look at his electrolytes and creatinine. So when you say chronic constipation in an HIV positive patient who's late stage, he has AIDS. This guy has AIDS. The first thing that comes to mind is some adrenal dysfunction that's real common late in HIV, and then that's associated with electrolyte anomalies. So you really need lights, creatinine, calcium, phos before you can give somebody Bactrim. Remember, initiating Bactrim is like initiating an ACE inhibitor It'll cause
Mhm.
hyperkalemia and elevated creatinine. So you can't do that without monitoring. So your option for someone who doesn't want to do monitoring is Mepron. It's an old anti-malarial atovaquone. You can just give them 1,500 milligrams a day, and there's no monitoring. There's no downside. It just tastes like swallowing paint. If that's a bad side, I think
you
that's
say
bad.
1,500 milligrams a day.
1,500 milligrams a day.
Okay, and
So-
actually I did get a CMP on him and his creatinine is okay. It's 1.02, EGFR was 85. And
Yeah.
his electrolytes were all within normal.
Amazing. So
Yep.
from an OI standpoint, it really, so the big picture, let me set the context on this guy. This guy's dying. I don't want to beat around the bush.
Yeah.
He is near death and is a razor's edge away from having his homeostasis perturbed and dying.
Yes.
Any little thing could do that to him. So there is huge amount of redundancy in late stage HIV/AIDS and opportunistic infection presentation. So you can't differentiate. They're all cachectic illnesses. You start wasting away. The major ones that you worry about that are late stage like this are the neoplastic variety, that's lymphomas,
Mhm.
and MAC, disseminated MAC, with his GI pain and stuff like that. I really do worry about disseminated MAC in him. So what I would do from an opportunistic infection workup standpoint, if you can, is AFB blood cultures. So AFB blood cultures, you'll never find it unless you do an AFB blood culture and see if he has disseminated MAC. You wouldn't want to offer him MAC prophylaxis until you've evaluated that, because he's clearly high risk of having disseminated MAC. If you're cured, remember most lymphomas in late HIV are driven by EBV, are driven by
Yeah.
Epstein-Barr. So you can also get a sense if he really does have a leukemic or usually it's lymphoma type process based upon doing an EBV in the blood, a quantitative PCR, not the serology. And if it's sky high, it probably does have a B-cell lymphoma of some form.
Okay.
And this is all depends what he wants to do. And this is a guy, if I met him with his complaints, I'd probably do a chest, abdomen, pelvis CT at baseline, almost like an FUO. He's a consumptive process of unknown etiology,
Mhm.
which could simply be his untreated HIV, or it could be an opportunistic infection. So remember, he doesn't have cells there to react to really tell you what's there. So
Right.
Big picture, to reset on the HIV, this is something where you are at a crossroads where he either pursues antiretrovirals or he dies.
Right.
And that's not, we've had patients who decide not to and go on hospice. I can remember a young man in particular who did that. He preferred, it's personal choice. But that being said, what I would do, I would spend an entire visit. Talking to him about what it was that he heard or personally experienced having taken antiretrovirals. AZT shouldn't even be considered a modern antiretroviral. It's chemotherapy. We don't offer it to people, especially the doses back in the late 90s or late 80s, early 90s. We don't even come close to approximating it. It was an anti-neoplastic agent with all the sequelae therein, so you don't use it. Biktarvy, however, is a placebo level side effect profile with unbelievable rapid efficacy. You never say never about drug side effects, but I've never seen someone not able to tolerate an integrase inhibitor-based regimen. So that's how confident I am. He didn't actually experience adverse reaction to it. Everybody who starts an antiretroviral will experience a day or two of belly upset. Talk to your patients on PrEP or anybody who takes any new drug for any form, heck, metformin, whatever. You get a belly upset for a little bit. They get used to it.
Yep.
The bigger thing is he might have experienced iris if he did take Biktarvy for a substantial amount of time and started getting bad belly pain it's because his immune system was rebooting and he probably was developing an inflammatory reaction to some unknown opportunistic infection. And so really clarifying what it is that he's phobic about, dispelling any myths, feel comfortable using the word placebo, because genuinely the Biktarvy is unbelievably well tolerated, unbelievably efficacious. The only thing people have problems with is if they get an iris syndrome following that. One comment about the genotypes. You guys don't even have to bother doing them.
Okay.
When they're not on antiretrovirals. So remember the weird part about HIV is it is a virus that archives every viral variant that's ever been successful in the human body. It's a retrovirus, so it keeps that archive. And the most fit of all of the viruses, the wild type. So when you're not an antiretroviral therapy and you do a genotype, what you're going to find is a wild type virus. So if somebody's previously been on antiretroviral therapy, the best thing to do is restart that particular antiretroviral and then repeat a genotype. And at that point, you can unmask any hidden, whatever it's called, resistance. But honestly, he's not going to have resistance. I don't think he took it long enough. It sounds like he maybe never even gave Biktarvy a try. But I'd spend an entire visit just being like, bro, we got to talk, man, because it's really all that matters is getting him on that. You know, his lifeline is you know, it's his only lifeline is going on antiretroviral therapies. And boy, oh boy, is it efficacious. You can offer him a couple of carrots too and be like, hey, we'll get you undetectable. Then you can just take a shot every 3 months or something, you know, every 2 months, because there's shots nowadays that can keep people undetectable. But with his situation, it's a bad idea up front. But he is, Joanna, I'm blown away by this case. Blown away. You are tackling, you literally, you decided for your, you know, the mountain to climb, you just shot for Everest. Like, this is ridiculously
well, you know, it's Everest, but if he decides that he doesn't want to do anything about it, he's a hospice patient.
Correct.
It's
you're right. And
either really complicated or really easy.
Yeah, no, you're right. I remember just being mind boggled by this patient that decided to go with hospice. And I was like, bro, it's a pill a day that's placebo level, but he was not hearing it. And you know, it was a personal decision I can't make as a, like you're saying, but boy, do your best to convince him that this is literally like, if he takes any pill a day and he won't, if he gives this time, it will not cause him trouble. Now that's outside of the iris. Remember, iris is being that phenomenon. As you reboot the immune system, you can react to any unrecognized opportunistic pathogen in the body. The most common ones we see are disseminated mycobacterial infections. So you're just running along, living perfectly happily with a mycobacterium hanging out in your blood, spleen, and lymph nodes. And then about a month after starting antiretrovirals, you get swollen, you get your adenopathy goes nuts, and you get belly pain, you get all sorts of whatnot. But really, any opportunistic infection you can imagine, you can get iris towards. So we see iris towards Hep C, which would present almost like an acute Hep C. You see iris towards CNS infections like toxoplasmosis and cryptococcus. So almost anything. You don't hunt for all those on day one, but just be cognizant of any decline that a person could have clinically. You're like, oh, crapola, it's a month into antiretroviral therapy. I could be seeing that. So I would just clarify what it is he did. Now, I would love if you can present this guy to us a few times so I can help out any way I can. But
yeah, I would like to do that.
Blown away.
Actually, that sounds great.
Climbing Everest, nuts.
Yeah.
Put Mepron him up. See if he'll swallow paint. Mepron. So.
We'll see what happens.
Thank you all so much. My camera and mic, can you guys hear me? Because my microphone said it's switched or something. So I'm glad you can see and hear me. But thank you all so much. Dr. Bailey, any other questions about your case that you wanted addressed?
As far as the iris goes, is this something like, could he get septic and end up in the hospital? Is it?
No. So they don't tend to get, it's something that scares us as providers. Patients don't really look that sick most of the time. I've only seen a couple of people get sick, and it's from sort of really complicated scenarios. But usually the iris is a febrile process, or you basically whatever disease state that opportunistic infection is claiming, unrecognized, will suddenly flare. And so a real common one is iris to cryptococcus in the brain. So you might see a person. Remember, cryptococcus is a meningitis that can take years to kill you, and you actually do fine. I've literally seen people in clinic who I'm sure in hindsight had yeast running in their brain, and then I started them on Biktarvy, and 3 weeks later they're comatose because as their immune system wakes up, their CSF pressure goes high, etc. Another example would be iris to disseminated mycobacterial infection. Again, that presents as adenopathy that gets worse rather than gets better with time. And so remember, all patients with HIV have tons of adenopathy, big spleen, big liver. That's just part of their, this guy might not because he doesn't have a lymphocyte to speak of. But anyway, in general, people have big adenopathy, and you start them on antiretrovirals and their lymph nodes eventually shrink. So if you see the opposite pattern, it often means there's an opportunistic infection running around in their lymph nodes. Could be Mycobacterium, could be Bartonella, but they present as like a, swelling in and it should be belly pain, bad belly pain, and or swollen lymph nodes in X, Y, or Z spot. So just look for like an unmasking of an opportunistic infection after about a month. It does not tend to cause sepsis. I've never seen anybody get really septic from it. I've seen some weird electrolyte whatnots and stuff like that, but I could walk you through that as we go. But get some baseline blood cultures on, or mycobacterial blood cultures, your EPP, start them on Mepron, and then have a whole discussion on like, how can I convince you that data that you have on antivirals is antiquated? Because he's running on 1990s data, and nowadays it's so safe, so tolerable. I mean, it's amazing. I would have hesitated to take AZT, and we give people PrEP nowadays because it's basically the same side effect profile as Biktarvy. So good luck, man. I'm glad he's in your hands. That's you're doing, I know you're gonna do everything you can for him.
I'll do my best. Thanks, guys. I really appreciate it. And everybody has to get back to clinic, so.
Yeah, no, thank you so much. And thank you, Carolyn. I saw you chatted in a fact sheet there, so I'll include that in the recap email. So appreciate that.
That's great.
All right, well, I will get into the announcements, but before I do, again, big shout out to our case presenters, Dr. Fournier and Dr. Bailey, and our presenter, Kaylee. What a great session. I always feel like that after all of these sessions, but thank you all so much. The only announcement that I have is the next time we'll meet is in May, which is insane. May 11th, and Angie Wojcik will be presenting on new HIV drugs and guidelines. So keep an eye out for that reminder. Thank you all again, and we'll see you next time. Take care.